Hi, and welcome to another video from the CTAD Clinic. My name's Dr. Mike Lloyd and I'm the Clinic Director. So in this video we're going to start looking at a number of conditions that are known to be associated with complex trauma and dissociation. But I think this is relevant for anybody suffering with these conditions as standalones because it gives, or hopefully will give, some indication as to what might be going on, why some of these things might be present. So today the first one we're going to look at is chronic fatigue syndrome, which is also known as myalgic encephalomyelitis, or ME. It's quite a mouthful. So we're going to sort of break things down and just look at things like chronic fatigue, which will cover everything, and that takes into account whatever we're looking at. Now, to start with, I just want to say that this is going to be approaching chronic fatigue as a condition that doesn't have an obvious physical or medical cause. So there are some things which might cause extreme tiredness for prolonged periods of time, such as post-viral syndrome, or even things like the side effect of taking chemotherapy. So there are some reasons why someone might get chronic fatigue in a very normal environment as a result of sort of other physical causes. So we're not looking at those. We're essentially looking at chronic fatigue as an experience that people have to endure and cope with for months and often years without any known medical cause. So it's been looked at, people have maybe subjected to all sorts of scans and blood tests and all these different things, and there's really been nothing as a biological marker which demonstrates why this might be taking place. So we're looking at this as being something that doesn't really have a sort of a known cause. And if we look at the two main sort of sources of information for this, which is the sort of the NHS website and the CDC in the USA, these are government level information resources, so they can be reasonably well trusted because they are written by medical professionals. And we get a bit of a sense from both of those, from the NHS and from the CDC, that there is no cause or really understanding of where this comes from. But they are validated as being conditions that are taking place, that people do have and people do experience. So chronic fatigue is a thing that people do experience. It's written about and it's known about in many different areas. So we know that this is true, but we just don't really have a good understanding of why this might be the case. Or so it seems. And I think when we look at the rest of this video and we go into some of the detail on this, we'll hopefully develop some sort of understanding as to what might be a significant cause for many people. In terms of what we actually know about chronic fatigue, then, it's a condition of extreme tiredness. So this isn't just like being tired because you had a day's hectic activity. This is tiredness that can just come and stay and remain for a long time and cause a great deal of distress and can get in the way of people's lives. So it's a dysfunctional condition that prevents people from being able to do the daily activities of life. There are four main symptom areas that I'll reference here. So I'll go through these one at a time. The first one is quite obvious, that it's about feeling extremely tired all of the time, and this can prevent people from doing the regular daily stuff, as I've said. The second is about sleep. So firstly, there can be a lot of sleep problems, but also even when there is a decent amount of sleep, the person wakes feeling not rested and still tired, even though they've had an awful lot of sleep. There can be what's known as brain fog, which is problems attending to or concentrating on things and really being able to focus on what's going on around. And the fourth one is that symptoms can get worse after almost any activity. So this is known as post-exertional malaise, or PEM. So almost anything that's done then leads to sort of an exacerbation or an increase in the sense and experience of fatigue. And when we look at the NHS and CDC sites, they also include pain on this, is that for many people, chronic fatigue is associated with pain. And actually what we see in clinical settings is that chronic fatigue and fibromyalgia, for example, come hand in hand, is that people often experience both. So there's a sense of extreme tiredness and there's a sense of chronic pain, both of which often do not have organic causes. So both the fatigue and the pain aren't really understood in medical or organic settings, but they exist and they are primarily there. In terms of trying to work out a diagnosis, so actually being able to say that, yeah, this person does have chronic fatigue or ME, how do you actually diagnose this? And there isn't really sort of a decent approach to this. It's more like a sort of a global understanding of the context of the person by getting them to describe all of the symptoms that are being experienced, the timing, the frequency, the intensity of those symptoms, and often your primary medical professional will label that. So your GP, for example, in the UK can set out a diagnosis of chronic fatigue. So the actual diagnosis of it is a little bit haphazard, and often people do self-diagnose with this because that's what they've been experienced, and they can go onto these websites, look and say, yep, I'm experiencing all of those, I have chronic fatigue. So it is one of those things that is quite difficult to accurately diagnose in terms of a structured assessment of diagnosis, but the experience of it remains pretty clear, because this is something, as I've said, can take months and years to be played out, and a person really understands where they're coming from in terms of their experience of tiredness. So when we thought about diagnosis, and we can be, fairly assured as medical professionals, let's say that there is the case, then those people will say, well, actually, what is it that the treatment can then be offered to try and help any person that's experiencing chronic fatigue? And the treatments are not particularly wide or varied. So they're quite limited in terms of what can actually be offered to people. A lot of it is about adapting to routines and patterns and trying to address any problematic patterns that might be taking place. So a kind of an activity regulation approach. So for example, using cognitive behavioral therapy, CBT, to try and analyze, break down and understand the nature of a person's activity levels, start introducing more periods of rest and relaxation, and really try and regulate the level of activity that a person is doing. Sometimes medicines can be helped, so in terms of affecting the pain or things like that some medication that prescribed by health professionals can be useful. Sleep is another one. So if a person's really struggling with sleep, then sleeping medication can help, and obviously pain medication, as I've said. Some of it comes down to what's called energy management. So this is about the sort of approach that we look at. For example, saying a person's energy is like a battery, that you've got a certain amount of energy available in that battery from day's start to day's end, and how you use that determines how fatigued you might end up being. So a lot of people then start having to work with diaries and things and look at what their energy levels are at different times of the day, whether that's then related to sleep or exercise or nutrition, and to try and understand where energy losses take place and to see what energy gains could also be had. So it's like a balanced management system. That can be really useful and can really help people to try and organize themselves. One of the classic things that we see presenting to us in clinic in chronic fatigue, and I'm sure this is true for all services, is this kind of boom and bust type thing. It's not boom or bust, it's boom and bust in this circumstance. And what can often happen in terms of a classic presentation is that a person, for some reason, manages to acquire a bit more energy than usual. They're a little bit upbeat, they've got a bit more going on, there's been a load of things that they've not been able to do as a result of the chronic fatigue, and they go into blitz mode. So for example, there's housework need doing, or chores need doing, or gardening needs doing, or painting the room suddenly needs doing, or redecorating, whatever it might be. And so they go for it with gusto, and they can do it for hours and hours and hours, and they feel great. And it's like, finally, I've got some energy and I can really do all the things I need to do. They get into it, and then unsurprisingly, the very next day, they are completely wiped out. So this is that sort of post-exertion malaise approach, that one day's exercise can actually cause like 4 or 5 days of complete fatigue, where they are almost incapable at times of doing really much of anything that they need to be doing. And that seems to be a pattern that happens. And then you go into those 3 or 4 days of fatigue, and the person is absolutely depressed and miserable and isolated, and they hate every moment of it. And then once that post-exertion malaise sort of wears off, they get more energy back, they suddenly then try and catch up all the things they've not done for those 3 or 4 days, and they go into this cycle that can repeat and repeat and repeat, where a lot of activity is then followed by a period of inactivity. That inactivity leads to a great deal of frustration, that when it's over leads to a great deal of activity, and so on. And that cycle can replicate itself. So one of the key treatments is identifying that, trying to break it down. Now, all this is really well because we know all of this stuff. So how does this actually sort of fit into anything new in terms of the work that we might carry out in a clinic such as ours, which is all about trauma? So we have to try and understand, what is it about chronic fatigue that means that so many people who come into our service and in other clinics around the country and around the world that present with chronic fatigue, and that might be the thing that gets them into services in the first place because it's something that needs addressing, and then yet they end up coming into clinics such as ourselves. So trying to understand the link between trauma and chronic fatigue is what's going to be really important, because chronic fatigue has this masking ability to it, that a person can go into into services, physical or psychiatric services, and they can have chronic fatigue. That can be the sort of primary presenting condition, and that can be all that gets seen. Like the whole focus and attention of healthcare gets put onto that chronic fatigue, onto the tiredness, doing activity scheduling and medications and CBT and all these kind of things to try and overcome and reduce the chronic fatigue to give the person their energy levels back. Which completely makes sense, because realistically that's what the person is looking for. I just want more energy. I want to be able to go about my business and not feel tired all the time. But if there is an underlying condition, if that is associated in any way to another condition, then the chronic fatigue, as with pain, we might come on to that later, the chronic fatigue sort of takes precedence, becomes the priority, and the focus of all interventions is on reducing the fatigue and then not maybe on what's being masked underneath. So we ask the question then, well, what could be the thing that sits underneath this that is so important that it's being masked and yet needs to be understood? So we look at the research and we try and do some basic sort of understanding of what is it that takes place. Now, us sitting in a trauma clinic, we get loads of chronic fatigue being presented in the patients that come into our service. A high proportion of them have chronic fatigue. So we have to think, well, maybe there's some sort of link between what we're doing, which is the trauma and dissociation, and the chronic fatigue. So we hit the research, we try and make a sense. Is there a link? Has this been demonstrated and has been proven? And thankfully, yes, it has. There are some really interesting articles that actually address this link between trauma and chronic fatigue. So one of these is a population-based study, and this is what it's called: The Early Adverse Experience and Risk for Chronic Fatigue Syndrome. And the authors are Heim, Wagner, and Maloney. So they're working from the States. So this is research that was undertaken in the States, looking at a group of people with chronic fatigue and a controlled sample. And this has actually been replicated. So other studies have been done similarly in different parts of the United States with exactly the same results. And what they have found is that the people that have chronic fatigue as their presenting condition that's diagnosed have a higher likelihood of adverse childhood experiences. So that means that the people that have been traumatized early in life by these adverse childhood experiences, which is often quite abuse type settings or neglect, all the sort of things that we know lead to dissociation, are present in people that have chronic fatigue in a greater degree. So what they are looking at then is basically saying that the people that have adverse childhood experiences, have these events in childhood, has a developmental process that takes place. It sort of causes a vulnerability to things like chronic fatigue syndrome, amongst a load of other things, causes a vulnerability to chronic fatigue syndrome later on in life. So the people that are most likely to get chronic fatigue are the ones who have been traumatized early in childhood, and they've developed what's called a correlational link. So they're not necessarily saying that the one definitively leads to another, but that there is a high proportion of one is associated with a high proportion of the other. And the controlled group that don't have a diagnosis of chronic fatigue have much less incidence of any childhood trauma present in their background. They're also looking at the possibility of a neuroendocrine dysfunction, because what they've also seen in the people that have got high rates of childhood trauma is that there has an effect on the cortisol, the stress hormone within the human body. So we're looking at a pattern developing whereby there are adverse childhood experiences, there is a stress hormonal change or imbalance, and there is chronic fatigue later in life. So we do have the sort of a known, proven, research-led link between childhood trauma and the likely presence of chronic fatigue. Again, it doesn't necessarily mean that one leads to the other, but the presence of both being in the same people so many times leads us to have the hypothesis that there is a associated link between these two different things taking place. And anecdotally, we would absolutely see that within our services. So every person that I've ever met with chronic fatigue as a presenting condition, either within dissociative services or in general psychiatric mental health services, when we get into the background of that person, there is always a trauma that has been present. I've never seen one without the other, in the absence of it being purely about physical health, like I said, someone on a chemotherapy trial. So every person that I've ever seen with chronic fatigue has had a trauma background. Now, when we actually address the trauma and stop just looking at the fatigue type things, then some really good things take place. Like some people start to recover and they get their energy levels back. But what I found is that doing the both, so working with the trauma and working with the levels of fatigue, doing all that energy management, energy activation stuff, that tends to produce the best result. Now, of interest, when we look at the CDC and we look at the NHS pages for this, is that it doesn't really mention trauma at all. So both of the pages talk about the various treatments that are available, and the CDC one goes into great detail about sort of sleep and depression and anxiety and pain and post-exertion malaise and all these kind of things, but it doesn't mention trauma. So if we know that in the research, and this is stuff that's been around for many, many years, has a proven link, correlational link between childhood trauma and the vulnerability to chronic fatigue, it seems a little bit confusing that the main treatment being recommended in the USA and the UK for chronic fatigue fails to mention trauma at all. It doesn't even say do an assessment of childhood trauma to determine whether that might be present or not. And I think that's a big problem. So when people are going into services with chronic fatigue, they're not necessarily then being asked about any childhood trauma. It's much more about symptoms and what's your energy levels like, what's your diet like, what's your sleep like. It's not saying maybe wonder what happened to you during your childhood. And I think that's a big problem, because what we also understand is that if childhood trauma is present, it has a long-standing impact across many, many aspects of physical and psychological functioning. And if the childhood trauma is not addressed and processed using trauma methods, then the likelihood of the person actually recovering from the condition such as chronic fatigue is going to be highly reduced. It's just if it's caused or if it's led to be as a result of childhood trauma without addressing the childhood trauma, what are we expecting to actually happen? Because the impact of that childhood trauma is like a ripple effect that just goes on and on and on. And we see that within dissociation services, because people left to their own devices tend to not get better from dissociation unless there is a targeted intervention for it. So if we're thinking about chronic fatigue, what we need to address then is a targeted intervention that includes both childhood trauma and chronic fatigue at the same time, in order to give the person the best opportunity of actually recovering properly, not just having symptom reduction, but actually recovering properly. Now, if we get into the deeper territory of dissociation, then we see how chronic fatigue can really sit and just be present in all aspects of a person's life, because we have certain aspects of it. We have things like dissociative amnesia. That means a person can't necessarily remember what they're doing or where they're supposed to be, and they don't really have an account of what's taken place. So we know that there are people who might have high levels of activity and they can't remember it, they don't know what they've done, so they then repeat, or they then completely miss out on things that they should have been doing. So we've got problems of memory. We've also got depersonalization, where a person is disconnected from their own body, so they're not really reading the signals from their body well. And people talk a lot about not being able to know when they're hungry, not being able to know when they're full, not being able to know when they're tired, when they need to go to the toilet, whether they need to go to sleep or not. They stay up all night, they do all sorts of different things. So not being connected to the body means not being able to read the body, which in terms of the energy management system of, say, the battery, is if you can't tell what's in your battery, if you have no means whatsoever of understanding when your battery is full or not, how are you possibly supposed to regulate the energy levels within the body? It's just not possible. So even our phones give us an indication of how much battery is left. So we're left to our own devices. We need to read our own bodies. And if we're dissociated from our bodies, we can't read our energy levels. We can't read when we're tired or when we need exercise, and therefore chronic fatigue, if present, is just going to sit and sit and sit and likely to become worse. Then we've got things like OSDD, Other Specified Dissociative Disorder, and DID, Dissociative Identity Disorder, where a person isn't necessarily in control of their behavior or their mood at any given time. They can be influenced from within, or they can be taken over from within, and they can actually start behaving in a way that is not conducive to good health if you've got chronic fatigue. So an example of that could be a person with DID, let's say, intends to rest. They feel tired, they intend to rest. So they take a break, they sit down and they maybe try and take a nap. But one of the alters in the system, who may not be have had much going on, or they have a different action system, needs to get up and get moving because maybe stopping or slowing down is seen as a threat, or maybe that causes flashbacks to take place. So the alter might come out, be present, and suddenly move the body up and start doing a whole load of things that the person isn't aware of. They might do that for an hour or 2 hours. They might then return to the couch to settle down. The person is then sort of returned to their own body, and they're absolutely exhausted, even though they believe they might have rested for 2 hours. So things like OSDD and DID can be extremely difficult in a person that's got chronic fatigue, because unless there's internal collaboration, there's an understanding of what's going on in that system, any chronic fatigue is likely to be made worse. So we have that sort of thing going on. We've also got a sense of a general lack of really being able to self-care, and childhood abuse, childhood violence, neglect, any of the kind of things that a person might go through in their childhood doesn't really lead a person to feel like they need to care for themselves, because they've not been cared for from the outside. So if the people that are supposed to care for you are actually causing you harm, you never really learn how to do self-care. No one's showing you how to do it. So people often ignore their bodies, ignore their sense of self-care, or they put all of their efforts and exertions into looking after other people, i.e. the sort of the people-pleasing type group. So they put all of their effort and energy into making sure everyone else is okay, and they don't actually address their own needs. And chronic fatigue is therefore, you can see how that will be present, because a lack of self-care, a lack of looking after yourself is likely to lead to fatigue. And there's more. I mean, this just goes on and on and on. So I hope you're still with me on this one. What we know, and I've looked at this in one of the other videos, is that the absolute presence of trauma in of itself is like a weight that is being carried. And you'll understand this when you hear that people say, oh, it feels like a weight has been lifted off my shoulders, when they've been able to share something difficult, or do some processing of an event or a trauma that's taken place. So we know that actually carrying trauma from childhood through teenage life into early adulthood, into adulthood generally, and possibly into older adulthood, actually wears people out. It's like if you imagine driving a car and you put it into the red line, you hit the maximum revs, and you drive that car for hundreds and hundreds and hundreds of miles, it's going to wear the parts out. And actually, this high level of activity that is designed to maintain trauma, especially if a person is dissociative, potentially has a really wearing effect on the system. So we'd almost expect chronic fatigue to be present alongside something like DID or the high levels of dissociative conditions within complex trauma, because the design is to keep trauma away. But that takes a huge amount of effort, and to maintain that effort can be extremely exhausting for people, to constantly be on the alert. What if my parts come out? What if something's going to happen? Completely fearful, hypervigilant, hyper alert, which are aspects of PTSD anyway. So anyone who's been traumatized is likely to become hypervigilant. That hypervigilant is exhausting. You don't get to relax. You're constantly in a state of anxiety. You're constantly in a state of dread or apprehension or fear that your threat system is going to be overwhelmed. You're all about protecting, all about trying to sort of maintain a safe life. And again, over the years and years and years that a person does that prior to coming into treatment, that can be exhausting. So what we see is that there may well be, from the research, there may well be a sort of a physical link between childhood trauma and chronic fatigue, led by the cortisol system, which is essentially part of our threat response system. It's our stress hormone, so it's all linked. It's also the act of maintaining a traumatic experience in life, trying to protect from it and trying to be vigilant against it happening again, could be extremely exhausting. And it's also that you may not have the self-care strategies that have been built in by good nurturing parenting experiences, because a lot of people with adverse childhood experiences are simply not being looked after properly. They're not being shown how to do stuff well. And what all of these things do, if we combine them together, leads to almost a completely predictable response of being exhausted all of the time. And if we think that chronic fatigue essentially is chronic tiredness, we have to ask what might be the factors that lead a person to become tired. And we have got a bunch of them with anybody who's got childhood trauma and then potentially moves on to becoming dissociative as a response. Simply living that life is absolutely exhausting. And if a person doesn't know how to manage or regulate their energy levels, then that exhaustion is just going to get worse and worse and worse the older the person gets. So targeting any treatment with trauma in mind, thinking about the neurobiology, the endocrine system of the individual, thinking about the adverse childhood experiences they've gone through, thinking about the routines of everyday life, is what we call a systemic approach to treatment. So you're not just looking at the symptoms, you're trying to look at the broader picture that might have led those symptoms to be the case, and then develop a deep understanding and then target interventions according to what is known through that deeper understanding. And that's what we try and do within this clinic, and that's what we advocate for, and that's what a lot of good services will be doing. But that's the case. And if a person has that chronic fatigue syndrome, if that's their presenting condition, it's not necessarily meaning that all these other factors will be there, but it's really important to check for them. And as a sort of a parting shot on this, because I know this has been a long video, so I really hope you're still with me on this, is that what I'd really like to see is that anybody who presents with chronic fatigue does a screening for post-traumatic stress, complex post-traumatic stress, and dissociation. Because if any of those factors are present, they absolutely need to be factored into any treatment interventions that take place for that individual. Otherwise, the likelihood of a successful outcome without taking that stuff into account, if they are there, is highly reduced. So if you want a successful outcome, factor in, develop the understanding of the potential for trauma, and then work side by side with the trauma and the chronic fatigue. And I think that gives the best chance of that actually working out. So chronic fatigue is definitely one of those associated conditions. We see it all the time. And therefore, I think we have to factor in that in a trauma clinic that sees chronic fatigue syndrome a lot, there has to be some sort of link. And if that link is not understood, then the person might not get well. So, again, really long video. Thanks for staying with us. I really hope that you've enjoyed this. I hope that you've taken a lot of this information in and can understand it. And I really look forward to reading the comments that come out following from this. So, I'm going to continue with doing the series on these conditions associated with trauma and dissociation. So, I look forward to seeing you all again next time. In between now and then, obviously, and as always, please do take great care.